Good evening, everyone. My topic is visual outcome and complications of secondary posterior iris claw intraocular lens implantation in aphakic patients. As everyone knows, cataract is the leading cause of reversible visual blindness across the globe, and most common surgery as of now is performed are like MSICS, flags, everything. Secondary IOL implantation in a case of loss of capsular support include angle supported anterior chamber IOLs, scleral supported IOL, and iris claw anterior chamber and retropupillary IOLs. So Professor John Wurst developed the IC IOL attached to the anterior iris in 1972, and secondary implantation of retropupillary have been the preferred procedure in cases where iris support is feasible. So this study was done to assess visual outcome in patients undergoing retropupillary implantation of iris claw, and to study post-operative complications of iris claw lens implantation and BCVA at the end of 3 months and 6 months, and effect on endothelial cell count. And the study included the outpatient department patients, and it was a prospective interventional study done for 15 months from August 2022 to September 2023, and this study included 63 patients. The inclusion criteria was patients willing to give informed consent, and patients with insufficient posterior capsular support, endothelial cell count of more than 1200 per mm square, and aphakic eyes with grade 1 or less cells in anterior chamber at the end of 1 month post-op following cataract surgery. And exclusion criteria were pre-existing retinal pathology and corneal pathologies, gross iris abnormalities like aniridia, traumatic cataract and complicated cataract, glaucoma, and patients with high myopia and uveitis. So the patients attending OPD were assessed history-wise, and the clinical examination was done, and all 63 patients were included in the study with inclusion criteria, and ocular examination was done. Surgical technique, a single surgeon after a written informed consent operated all the cases. Following automated anterior vitrectomy, the patients were implanted with XL iris claw lens with a total length of 8 mm and 5.5 mm optic size. The size of the incision was 5.5 mm and superiorly was taken, and the iris claw inserted at 3 o'clock and 9 o'clock position. And post-iris fixated IOL was implanted using an iris claw IOL forceps. Peripheral iridectomy was done, and suture was placed to seal the wound. Follow-up was done 1 day, 4 weeks, 6 weeks, and 3 months and 6 months. Specular microscopy was repeated at 6 weeks and 6 months. The results were, according to the age group, many of them were 61 to 70 years, and most of them were males. And according the right eye was most commonly preferred over this study. And postoperative best corrected visual acuity was improved to 6.9 to 6.6 by the end of 6 months. And the refractive error most commonly was noted was compound myopic astigmatism. The preoperative evaluation and the postoperative evaluation of the endothelial cell count showed significant results, and the 2.8% loss was noted at the end of the study and at the end of the 6 months. This was the IOP variation. And the most common complication noted was fovalization of pupil and the iritis, which was the most common complication. And this was the most common complication, that was ovalization, which was seen in our patients. The best corrected visual acuity was found to improve significantly by the end of 6 months, and ECD loss was not significant due to position of the IOL away from the corneal endothelium. Cystoid macular edema is noted only in few patients and was noted resolving with reduction of macular thickness. And retropupillary ICIOL implantation in eyes with inadequate capsular or zonular support is safe, faster, and effective procedure with good functional outcomes and fewer complication. Thank you.
So what was your incidence of TAS? I think
yes, ma'am.
Shown that.
Yeah.
What was the incidence of TAS?
Yes, ma'am. 73% was noted.
How much?
73.
Isn't that too high?
Yes, ma'am. It was too high, and like after 2 days, it was resolved.
No, obviously TAS will resolve.
Yes, ma'am.
But why should you have TAS so much, such a high percentage?
Because initially it was noted due to NS, ma'am, and then we stopped, and it was almost normal after 2 days. So, and then we thought this might be iritis. So we included that in iritis part.
So that means you were having the same
Yes, ma'am.
symptoms,
Same symptoms.
same findings, but
Yes,
you then
ma'am.
put it in the bracket of iritis.
Yes,
Is that
ma'am.
it?
Okay. Yes, ma'am.
Was this procedure a primary procedure or a
Secondary
procedure?
procedure. Secondary procedure.
And was the suture given to these
Yes, ma'am.
patients?
Suture was given to all the patients, and it was removed after 45 days. And then this astigmatism and corneal endothelial cell count was taken at 6 months and 6 weeks.
How did the intraocular pressures behave in these eyes?
Ma'am, initially, due to iritis and all, it was high, and then it was managed medically, and it was fine at the end of 6 weeks, ma'am.
What about the endothelial cell count?
It was not significantly reduced, ma'am. It was only 2.8% loss at the end of 6 months we've noted in this study.
So, in your study, which was the most common complication?
That was like iritis at the end of the 2 days, ma'am. Like
73%.
Which is very. Thank you.
Thank you, ma'am.